Okay, good morning, the people on this side of these oceans. Good evening, the people back home. Good afternoon, whoever is afternooning. Welcome to, this is the last session this year because we give permission to our host country, Kenya, our home country, home host, to have celebrations and to be broke in December and January. So we will actually return in February. But our conversation today is on endometriosis. And as usual, Kituo will be opened by my fake co-panelist, Saya, and then we will take it from there. So Saya, you're up.
Okay, a point of correction. Kenyans are rich in December and then broke until February. Hi, everyone. My name is Saya. I'm glad to be here and glad that you've been with us for the entire 12 months that we have, okay, give or take the better part of 2023. Today we're talking about pain, and the problem with the pain we're talking today is it often is invisible. You know, when you're having a bleeding cut or a broken bone or a swollen thing externally, it's visible and easier to empathize with. But when the pain is not necessarily immediately visible, things become a bit more challenging. There are individuals who begin then questioning the legitimacy of the disease. Well, it's real, but it is not visible, and so they don't know about it. And then two is there's a lot of ignorance or a lot of normalization. People have normalized menstrual cycles with pain, and so when people begin saying, hey, I'm painful, they just told it's part of it. Or people who have oversimplified the solution, and they're simply told, even by various cadres of medical practitioners, who just simply summarize it by get pregnant or get a child and you'll be fine, you'll be able to cure it. So it's a pain that is invisible, and then because of the subsequent quality of life issues, and at times because it's very attached to the ability or inability to have children, there's a psycho and the social dimension to it. It makes the whole question of endometriosis become a very important thing for us to discuss. So earlier this year, we had a discussion about infertility, but there was desire for us to tease out from the whole family of infertility and maternal health and just zoom in on the question of endometriosis. As a disease that we've been able to label and get a name and more awareness, at least within our circles, Kenya and within our circles fairly recently, there's still a lot that is either mythinized, that means there's a lot of myths going around about it, and there's a lot more that we still do not yet know. Do certain foods cure or increase the risk to endometriosis? Do certain sexual practices outside of marriage increase? Is this a question of hygiene? So I've had all manner of things, but it is time that we bring some measure of peace and relief to those who are suffering from this, or those who are supporting individuals who are going through endometriosis, and be able to address the myths, the truths, the medicine behind it, but most importantly, to also extend empathy with understanding to the individuals who are navigating seasons with endometriosis. So the most insensitive thing you can tell somebody going through pain is either even me, or yours is not like me, or remember a time like me. And so I'll not do that because I have one disadvantage. I'm a man. I do not menstruate, and I do not therefore experience menstruation. Therefore, I will not venture into the insensitive terms of I feel you or I know I don't. Okay, but the best thing is to bring together the experts who are capable of shining more light to this. And therefore, without further ado, I'd like to return it back to studio, and let's have this authentic dialogue about endometriosis. Back to you.
Asante sana. So let's we are gonna start with the anatomy. Just give me a minute. In the famous words of Zoom, can you all see my screen? Thumbs up if you
Yes.
can see my screen. Okay, so let's start with I don't know, the medics who's comfortable doing the anatomy. I know Vicky has a model. Let's start with the medical side and then we'll go to the physio side. In a nutshell, what the anatomy of the pelvis. Just bear with me and use what I have. Jackie, do you want to take a stab? Just at a top level, as in, do you want to, so that people can know where just the organs that are swimming or floating down there. No, they're not swimming or floating, they're there. Okay, go ahead.
Yeah, absolutely. Thank you so much, Asrani. And I'm very glad that I'm part of this dialogue this evening. I found myself doing a lot of work in endometriosis. I'm not sure is by choice or is by circumstances, but what has just been introduced is something that we continually see, and unfortunately, endometriosis is something that we still have very little understanding about. But we have some descriptive to try and explain endometriosis, and I'll just use the model that you have here. And maybe in the subsequent slide,
just the anatomy first,
so
that we know the normal, and then we go to the.
Oh, absolutely. Yeah. So
okay.
I use the model that is on. Okay, well, my left, and so this is an abdominal cavity, we call it, which is devoid of what we get to see, and what we see is a skin that really lines the structures. So what you are seeing here, and I want to concentrate basically on what look like coily structures, which I think most of us know that these are the intestines, and this basically takes the abdominal cavity. And when you see at the very base of the intestines, you'll see a structure below, which is the uterus, and now that splits and makes that the pelvic space. So the pelvic space, now I will jump to the diagram that is on your right, which now it's made clear where you have the uterus, you have the bladder on the anterior or in front of the uterus, and behind the uterus, you'll have the rectum. And all these structures, they share this space called the pelvis. And when I talk of the bladder, the uterus, and the rectum, of course, the vagina, which is below the uterus, all these structures are very important when we'll get to a point of discussing the anatomy and endometriosis.
Thank you. Vicky, unleash your model. Are you still there? Let me stop sharing so that you can, yeah, because they need to see the pelvic floor itself. Okay, just go ahead.
So Dr. Jaggi has just explained about the abdominal cavity and the uterus wall, and this is the pelvic, how it looks like. This is a model for pelvic floor, and the pelvic floor is made up of bones, made up of muscles, which you can see they're red in color, and then made up of ligaments and blood supplies, blood arteries and nerves. And when you look at it, you can see these are the two seat bones, which in a layman language will say two seat bones. And then we have the pubic here. Then we have the spine. So the pelvic floor acts like the foundation, and it plays very great role. And one of them is stability. Without the pelvic floor, there is nothing to stabilize the lower extremities. There is nothing to stabilize the spine. And then the second one, it supports the pelvic organs, which is basically the bladder, the rectum, and the uterus. And that is usually supported by the pelvic floor muscles. And the pelvic floor muscles, we have the outer layer, which forms the urogenital triangle. And then we have the deeper layer, which basically forms the anal triangle. Then we have the second layer, which forms the sphincteric muscles.
Okay.
Then the other function which it really plays is sexual function. Without the pelvic floor, will not be able to make generation continue. And then the other function is blood. We call it sump pump. So it basically supplies the pelvic floor contraction muscles. They cause enough blood supply. They supply the area with enough blood so that the muscles can be able to function. Back to you.
Yeah, thank you very much. And then so the next let's see. So the next anatomy, okay, I think this is a Jagi and Ondegwa part. So let's discuss the uterus so that people, and then if any of you can take up what normal menstruation looks like. Jagi, Degwa, whoever, 10, whoever wants to take a stand.
Okay, I can take this one, Jackie.
Okay.
So
Yeah, sure.
basically, and it's a pleasure again to be here. I'm here for the fertility side, but endo is part of a lot of what we manage sometimes. So this is a really nice picture of our wonderful reproductive organ for women. I'm seeing 02, so I'll start with 02, which is I think the ovary or around the ovary and the tube. So that's the aspect of the tube. And if we follow through, we go into the uterine cavity. On the lower end of that hollow space is the cervix. And as you see down is the vagina. So this is the basic structure of the uterus, ovary, and fallopian tubes. I get a lot of questions as to one, whether the tube is attached to the ovary. I just want to make a disclaimer, but that the tube, not like we in school, I think the books used to show that they were in biology used to be attached, but they are not attached. The ovaries are on their own, and the fallopian tubes actually move, and one fallopian tube can even go to the other side and pick up an egg that is ovulating from the other ovary. So that's important to know for this structure. I'll run you very quickly through what happens in a menstrual cycle. So during a woman's reproductive age, and that's usually from the age of, it used to be 14, but now we're seeing younger girls starting their menses at even 9 and 8. So there is a shift to menarche, that is the beginning of the menstrual cycle, to the end of the cycle, which is menopause. What happens usually is on day 1 of your cycle, this is when everything starts. So your first day of your menstrual cycle is when everything is starting. And the goal of the menstrual cycle for a woman is for her to actually ovulate. So the menstrual cycle, what we want to do is achieve a pregnancy within the menstrual cycle. So on day 1, what happens is usually there are hormones that are very low that start rising to start up the egg that will ovulate to actually start growing. So these are called FSH and LH. I think it's a little technical, so I won't go into the deeper part, but these hormones start getting start increasing. And once they increase, what they do is that they stimulate the ovary to produce follicles. Now, inside a follicle is usually the ova. So that's the genetic element that we are going to transfer to the baby as a woman. So this follicle starts to grow, and usually there is a peak of the LH, and what that does of that hormone, what that does is allows the ovary to actually the follicle to burst and release the ova. Now, what happens is the ova is then on the ovary collected, the fallopian tube scouts and actually comes quite close to the ovary and allows facilitation of the ova to enter into the fallopian tube. So in the first half of the cycle, what is actually happening before you ovulate is that follicle is producing estrogen, and estrogen is allowing our womb to actually proliferate, which means that it's starting to increase in thickness, more blood supply at that area, because what it's anticipating is that this ova will actually meet a sperm if you have intercourse on that day of ovulation or around ovulation, and the sperm goes from the vagina. If you remember the picture, goes from the vagina to the fallopian tube, and they actually meet and then form an embryo, which comes down to attach to the uterus. That's what the hormones are doing. They're trying to prepare the womb to actually be receptive to this embryo. So your body is very, very organized. So what happens is that about 7 days after you ovulate, your body may realize that there's nothing implanting. So if there is a realization that we're not implanting, what happens is now we start moving to another cycle, which is that the progesterone level starts falling. It was rising in anticipation of waiting for pregnancy, because progesterone is a hormone of pregnancy. But if no pregnancies, no implantation happens, then now what happens is that lining now starts to realize there's nothing here, and it gives a signal now for the hormones to start thinking about shedding. And so the menstrual cycle, which happens about 7 days later, day 28, or whenever your cycle, it may be further on, depending on the cycle length of different women, is that that endometrial tissue that was thickening in anticipation now sheds. So another myth that I always get asked is, my tubes are blocked, how am I menstruating? Your tubes have nothing to do with your menstrual cycle. Your menstrual cycles is actually a function of ovulation and a function of the endometrial tissue, which is the inner lining of the uterus, shedding. I hope that's clear.
Yes, very, very clear. Now that we know what's normal, let's go to endometriosis now. Okay, and Jaggi, this is you now. So just that definition, and go whatever you can. What happens during endometriosis? What
Okay.
What is it? I was gonna
Okay,
ask.
sure. Please don't. Time is coming when you'll be allowed to press. So please hold it up. Okay. So if you allow me, I'll just do a quick presentation here for our viewers to kind of have an understanding now that we have normal here, if that's okay. I think this will be the one that I want to share. Can you all see my slide?
Yes.
Okay, fine. Let me go back. So this is a normal anatomy that we have just discussed, and something I just want to add, and I'll make clarification as we go ahead, is different parts of the uterus. And Dr. Ndegwa has, really explained the menstrual cycle, exactly what happens, the thickening of the endometrium. So if you see my pointer here, the uterus has different layers. We mostly interested in the middle layer here, which is the endometrium. And the endometrium is the one that is responsible for implantation, thickens, and if you get pregnant, hormones that called progesterone, which is mentioned, will maintain the thickness, and if no pregnancy happen, is going to shed off. And then we have this cyclic menstrual cycle. Now, endometriosis, therefore, what is endometriosis? So endometriosis, and this definition is very, very important, and I'll mention to you why we still say if we don't get the basics fast for endometriosis, is most likely everything else thereafter, we are going to get it wrong. I'm not sure if any one of you heard the show View by, what's the name of this lady, Gold something, when she was talking about endometriosis, and she was saying that she had endometriosis and she was treated with antibiotics. And for us who are on endometriosis, we are very upset of that misinformation and misinterpretation. And we felt that the problem was from the basics, which is the definition, where endometriosis and endometritis, possibly she was talking about endometritis, was totally different. Now, endometriosis, therefore, is condition where you have the presence of tissue similar. And I say similar because most people have said endometriosis is when you have the endometrium outside the uterus, where we have found that is incorrect. because we have found that there's quite some significant difference between the endometriotic tissues and endometrium. So the correct definition is the presence of tissue similar to the endometrium outside the uterus. Now, when I was talking about the anatomy and I talked about the significance of the structures, we've talked about the pelvis, we've talked about different structures. We have the bladder. Now, the endometriosis has a tendency of invading or growing in almost every tissue that is around the pelvis. So this is the uterus here. We see the ovaries, which we have talked about. We've seen the fallopian tube, and endometriosis has just that tendency. Now, here you can actually appreciate this is the uterus, the fallopian tubes on the right here, and you can see the ovary is quite enlarged, and inside the ovary, you can see this different colored content, and this is usually, you have this chocolate substance, and that's why the endometriosis on the ovary can either be called chocolate cyst, we call it endometrioma. And what I really want us to appreciate is that you see how the tendency of structures then adhering together in different stages of endometriosis. I will show a different structure here. So when we have endometriosis, we can have different levels of endometriosis. So assuming this is just the tissue lining the pelvic cavity or abdominal cavity, which we call it the serosa, or the tissue lining the peritoneum, which is, lines the structures around the abdominal or pelvic cavity. Now, we have the tissue I've just mentioned, which will now invade the peritoneum or the lining of the pelvis, and then it will start to grow. Now, the reason why we say these tissues are similar to the endometrium or the lining of the uterus is because they will respond to the same hormonal influence as the endometrium. Now, remember, endometrium will thicken in preparation for implantation. If pregnancy does not happen, it's then going to shed off and the process will repeat. The same thing we see with endometriotic tissue. Under the influence of estrogen, is going to start becoming active and proliferation will start happening. And when that happens, then this tissue will start getting the inflammation. Inflammation is just the changes and reaction. Now, as disease proceeds, now we can have this is more isolated or it's more confined at one location here. As the disease progresses, now you can find that it starts extending from where initial origin of the disease was. And now here you can see this is the uterus. This is the opposite side. You possibly have the ovary here or the fallopian tube. Now see, more surface area of the lining of the pelvis has been involved by the endometriosis. In severe cases, this is now where you're going to find out the disease has progressed. Maybe this is 5-10 years down the line, and now almost the tissues surrounding the pelvis will have to be affected. And at this point, now this is when we say that endometriosis is affecting fertility. Now, the question we get to be asked is endometriosis only a disease of the pelvis? The answer to that is absolutely no. Endometriosis has a tendency of just involving almost any structures. And that's the reason why endometriosis is called a disease of theories. There is no one believed believe that this is how endometriosis develops. People have talked about retrograde menstruation. People have talked about different theories. Now, we actually don't understand how the disease happens. Now, this is a 13-year-old girl who every month she would actually have this bleeding from the ears. You can actually find bleeding from the eyes. We have found endometriosis at the scar tissue. When you have that beautiful cesarean section, we can have implantation of the tissue at the scar. And when the woman is getting menses during her menstrual cycle, then at the scar place, they will also be experiencing the menstruation of the bleeding. Again, I have mentioned that endometriosis can invade the bowel or the intestines close to the uterus and the structures at the level of the pelvis. We have also seen endometriosis in the eye. This is a patient who would get this reddening of the eye every time she was getting menstrues. The ophthalmologist saw the patient, say we need to take a biopsy. Of course, for us doctors, for us to find what's going on, we need to take a biopsy. She declined. And then she saw a gynecologist because she felt this had something to do with the menses, because when she was off her menses, her conjunctival was okay. But during her menses, she would get this very conjunctival inflammation. Then when she was put on hormonal treatment, this all clear. So we have actually seen endometriosis of the earlobe. And just basically, that's what we know about endometriosis. So endometriosis is, it's a very mysterious condition. And that's the reason why making diagnosis of endometriosis sometimes can be quite challenging.
Wanjiro, do you want to add anything to what Njagi has said?
I don't think so. I think he's done a really good job at saying what endo is all about. Maybe just the causes, but he said it's really a theoretical disease. We do not understand why some patients have endometriosis. We do think sometimes there is a genetic link because you can see it in generations. But in most cases, we can't tell you this is why it has come. It's really theoretical. But it's like he said, it's just it's one of those things we don't wish on anybody, because as you've seen, it can appear anywhere in your body.
Okay, and one is a fast age, Kizungu. What's a fast age you can be diagnosed, and what's a last, like what's the period? Is it from menarche to menopause, and what's the earliest age we have seen children? Are these 8-year-olds getting endometriosis?
I think, from Jagi's, the 13-year-old, it's estrogen dependent. So whenever your estrogen starts rising, so it's within the reproductive age.
Oh my God.
Yeah, precisely. And I agree with Dr. Ndegwa that we mostly see the symptoms arising this particular period of reproductive age, but also we have seen endometriosis in postmenopausal. What is actually very interesting, and that's why we have theories like, what we call the Coelomic theory. It has been found that, like, even in fetuses, autopsy, they've actually have found evidence of endometriosis. So, of course, the symptoms will start at the point of when women start getting their menses. I would say the youngest patient I've had, with endometriosis requiring surgical procedure has been 15 years old. But we've actually seen even patient postmenopausal with endometriosis. It's only that now it's worsened by the influence of estrogen primarily. But endometriosis cannot be confined, that it's only confined at the age of menarche to menopause.
And I think to explain why it's estrogen is because we still have estrogen as women in our fat cells. So therefore, even after menopause, you may not be having as much estrogen, but you will still have estrogen being formed in our fat.
Absolutely.
Okay. I'm just confirming with Becky, she's fine because she's actually recovering from surgery. So Becky, you're good?
I'm tired, I actually want to sleep, but I'm here for all of it. I'm just nawasikiliza. I am shocked. I'm also learning a lot of things.
Okay. Tunashukuru.
So maybe Dr. Ashwani, before I forget, because there's something I don't want to forget as we proceed here, because Dr. Ndego has mentioned it. And I think this is one of the myths, if you allowed me to mention this, is when we talk about endometriosis and estrogen, there has been one misconception whereby it felt that the estrogen, it's produced by the ovaries. And this is whereby we've had numerous patients being offered treatment of removal of the ovary, what we call oophorectomy or hysterectomy, as an option of treatment, which I think is a huge baloney, because we know that endometriosis now has a tendency of producing its own estrogen. So even with devoid of the ovaries or the uterus, you've actually not done anything to endometriosis. So I think that's very important as we are talking about it and, difference of the estrogen. We also need to know that it has its ability to produce its own estrogen. And that's very, very important, because we've had so many patients who have lost their ovaries as treatment options for endometriosis. Yeah.
And I think Becky will come to that, right? Because we've had this conversation about your ovaries, and anyway, let's talk about the symptom. No, Vicky, is there anything? Because sometimes we MD world people might miss out things. Is there anything the physios generally pick up that we don't know about endometriosis?
I think the physiotherapists, what they pick, it's basically the musculoskeletal changes and the nerve changes because of the chronic pelvic pain, which comes with endometriosis. And basically, we come in to treat the symptoms once the doctors have dealt with the main cause. Once Dr. Jackie deals with the removal of the endometrial cells which are outside the uterus or which are growing somewhere else, then the symptoms, we deal with them, because they will always experience the symptoms of bladder dysfunction, bowel dysfunction, nerve pains. Most of them, they have posture issues, they have diaphragmatic issues, and that's where pelvic floor dysfunction, and that's where we all come in to work together as a multidisciplinary team so that we can get good outcome.
Okay, so let's go through the symptoms. Let's start with Jackie, then Becky, you'll tell us your experience in terms of symptoms. What symptoms does endometriosis present with? The typical ones, like I know we females, women are allowed a level of dysmenorrhea, like a painful periods, but when is it off the chart? When do alarm bells start ringing in my head, like that's not normal?
So by and large, and let me see if I can no, this is not here part of my presentation. So the commonest symptom for endometriosis is pain, pelvic pain. More commonly, pain during menses, which is called dysmenorrhea. So it has been mentioned that menses should be painful. Sorry, unfortunately, I cannot really rate the pain of menses because, of course, I'm a gentleman. But what I understand is that pain during menses, in the sense whereby it's going to affect your quality of life, it's going to affect your work performance, it's going to affect your conjugal responsibility, it's going to require you to take pain medication. It's just that pain that you have to plan your life around it. Then that's not normal pain under all circumstances. And it's actually been found out that more than 80% of patients who have this extensive pain during their menstrual period, they could be suffering from endometriosis. So the first sign that we see that could be, and this is what we call symptoms suggestive of endometriosis. We have to be very clear that dysmenorrhea or painful menses is not endometriosis. There could be other factors or other causes of pain during menses. But the commonest one that we have actually found over time is actually endometriosis. Now, pain, this pain that you feel in your lower abdominal or the pelvis that is just there, that is not disappearing, which we call pelvic pain. That can also be another sign of endometriosis. Pain during sexual intercourse, can actually be suggestive of endometriosis. What has actually been interesting, and some of the patients who have come to us is like, but I've been having this this pain during sexual intercourse, and I've seen my GP and has been told that is the position. We've tried to try all different positions during coitus, and nothing seems to work. So if you're having the pain during sexual intercourse, then that can be suggestive of endometriosis. And allow me to share my slide again, because I really need to explain why that is. And I want to go to this slide here. So if you appreciate this image here, most of endometriosis, where we see endometriosis, usually start from behind the uterus. This is where the growth of endometriosis starts. Now, this is the tubular structure here. This is the vagina. And during sexual intercourse, if you have endometriosis behind the uterus, which is the commonest location where we find endometriosis, during deep penetration, there's going to be irritation of the tissues behind here. Remember, they are going inflammation. The pain threshold is slightly higher because of the inflammation. And during the stretching of these tissues, that most definitely is going to present with pain. Now, other symptoms that we've seen suggestive of endometriosis, I've talked about pelvic pains, sexual intercourse. I have explained about infertility. Why infertility? The reason is this, and I think Dr. Ndego will be better placed to explain this. In a normal circumstances, after ovulation, the fallopian tubes usually capture the egg, and then after capturing the egg or pick up of the ovum, then there's going to be the propagation of that the ovulated egg in the fallopian tube. The sperms will move on the opposite direction. Fertilization will happen. Now, endometriosis, because of adhesion, is going to cause a kinking of the fallopian tube. It can lead to tubal blockage. It can affect the quality of the ovum. It can affect the process of ovulation. And more importantly, because of the inflammation, we have seen endometriosis causing issues with the receptivity of the endometrium. Now, of recent, what now we are really seeing, and this is common, and I think it's the next big issues, is mental health with patient with endometriosis. Can you imagine? You have had this patient for so many years, 5, 6, 7, up to 10 years. She's been having this pain for menses, and she has been, taken on this gaslighting that her pain is in the head. She has no issue. Of course, this patient will develop mental issues. So these are the commonest symptoms that we see. But what I've actually talked about is mostly symptoms for endometriosis in the pelvis. What about patients who have diaphragmatic endometriosis? They are going to have this upper or lower chest pain, and we find some of the time that pain is radiating to the shoulder, and because of the irritation of the diaphragm, it can irritate nerves, which then patients are going to have referred pain. What if patient has endometriosis in the lung? They can present with this cyclic coughing of blood or difficulty breathing around the period of endometriosis. So there are quite different varied symptoms of endometriosis. So this really helps us to suspect this endometriosis, and more so, where could this endometriosis be? Very unlikely do we find diaphragmatic endometriosis without pelvic endometriosis. The unfortunate bit is the following. Pain does not suggest or does not tell us anything about the stage of endometriosis. You can have a patient who has very early disease of endometriosis. They have excruciating pain. Whereas you find somebody who has an advanced stage 4 endometriosis, their only symptom is infertility. They have no pain. So there's very discrepancy between pain and stage of endometriosis.
So it pelvic
Vicky, just a minute. Your audio is choppy again. Just rectify that, then come back. Okay, Jaribu tena. No, we can't hear you. Just speak and then we to skip. Just try.
Yeah.
It's still a bit choppy. Yes, and we can take a moment of silence because even me who has been preparing for endometriosis for since we thought about this topic, I'm feeling the pain and I don't have endo. I'm just feeling, Becky, my heart out to you, and everyone else who's an endo warrior, my heart out to you. As we wait for for Vicky, let's Becky, let's before you sleep, because I know you're suffering, and thank you for being with us here. I think you're the fourth person with a lived experience. We usually don't put people with lived experiences because of the trauma, and we just honor your presence. But let's start with how long did it take you to get a diagnosis, and what was happening? Like, give us a story. Don't traumatize us, Sana. We are already traumatized from Jagi and Degwa, but just try. Give us your story.
I am actually having palpitations, anxiety. It's very triggering, like, because, and I keep telling you this, Posa, like, there's no way to break this disease down for anybody. So I think with hindsight, if you ask me, I think I had endo like from way back in secondary school. But it's those ones for the school nurse who will tell you, and I wish my mom was here, because you see, when I was in high school, I was convinced that I'm pretending, because that's what people would say. You're pretending. It's just periods. In fact, that's what they say. What kind of periods are you having that you can't take ibuprofen like everybody else and go to class? Because it would come with diarrhea, fever, nausea, the puking, the whole shebang, you know? And at some point, I was bleeding too much because I was anemic. God rest my dad's soul in peace. My dad literally walked with me through that journey, because now I couldn't, now school diet, and I had to be put on special diet, but even special diet for school could not cut it. So, and I was too sick to even do laundry. So my dad sometimes would have to pick my laundry during Sabbath, like when you'd come for church on Sabbath, he'd pick my laundry, go with it, do the laundry, bring it back. It was crazy. And then you begin to understand yourself now as a woman, and you get into the world and you don't understand what is going on. My ex-husband would be the perfect person to come and tell you that I flipped. I didn't even know at the time what was happening. But when Dr. Njagi spoke about the depression, I'm here battling it. The huge chunk of my anxiety and depression comes from endo. And so, you're sick, you're having extremely painful intercourse. You're trying to explain to your partner that you cannot involve yourself in sexual activity. But then they're like, what do you mean? As in, I don't understand what you're trying to tell me. So you're sick every day of the month, and it went on and it went on and it went on, and it got so bad in 2018 when my dad passed away. I think at that point now I'd reached the peak. I was suffering. So you learn to live with it, where you know that 2 weeks to your period, you're a person who's dying. So, and then your period will come and you don't know when it will stop. That was now for me the point at which I was like, this is madness. Now I have to see a doctor. So then my mom suggested I go to Metropolitan Hospital in Buruburu. I was still in Kenya by that time. I went, they did the ultrasound, they did what? And as Dr. Njagi has said, I was told there's nothing wrong with you. So they gave me birth control. They were like, it's just hormones, so take birth control. I'm like, okay, now me with birth control at Wendani, like, so this is me coming from my Adventist medical missionary things. I'm like, but why are you giving me these things? Like, I didn't, but then you start taking them and they are making my nausea worse. Birth control is now making me have iron taste in my mouth. I'm like, I can't do this, but I'm not getting better. I'm just getting sicker. And it's that come after 2 weeks, come after a month, come after what? So my sister says, no, I know a very good guy now. He's in I don't remember the place. It's somewhere uko on Wayaki, Belembele. And so I was like, yeah, so let's go and see him. And so when we got there, he did extensive research. In fact, just from talking to him, because he said I need to take medical history, and just from talking to him, he was like, I suspect, and I strongly suspect you have endo, because even for me, conceiving it wasn't easy. Like, that's the part I don't talk about, but conceiving was very hard. My child is he's a gift. We call him Howie because he's purely luck. Like, it was very hard to conceive. It was also very hard to carry the pregnancy to term. It attempted to abort so many times. And I don't know, I think it's just God's sustenance. And so then now I have the diagnosis. So what's the course of treatment? And then you realize we're all shooting in the dark. Like, nobody knows what they are treating at this point. So then the dance begins. I'm severely anemic by this point because I now got to a point where I was bleeding every single day of my life. I moved from putting on normal pads to using adult diapers because the flow, it cannot take the flow. My hemoglobin was constantly at 4.7, 4.8, panda 5.6. That's the highest it could go. My brother and my mother, if they were not spending their money on treating this disease, they would be billionaires, I swear. Because, and it doesn't, I can be very fine right now as I speak to you, and in 10 minutes, I'm dying. I'm somebody who needs to be in the ER. You need tranexamic acid to stop the bleeding. And then even when tranexamic works, it's stopping the bleeding for like 3-5 days. We are back to square one. We are bleeding. I need blood transfusion, iron transfusion. It's messing with my bone density, my teeth, my eyes. I cannot, I don't know what is happening because even as I'm speaking to you, I'm not well. Like I was telling you the other day, like it's like you keep going for one surgery and you think it will be the last. And then the doctor says, aha, something else is wrong. And from what I have learned is that my doctor keeps saying, every new symptom means the problem has gotten bigger than it was before. And I swear, every day there's a new symptom. I am fresh from surgery. When did I have surgery? First. I had my surgery on first. I'm fresh from surgery and I'm having pain. And now I'm just like, people think you're pretending, first and foremost. And then people get tired because everybody keeps going like, how pony? And people act like it's something you can fix with Panadol. It's something you can, the fatigue is out of this world. The fatigue, the mental instability, the bloating, the constipation, which I have, terrible, terrible constipation. For you know this because I'm constantly in your inbox saying, I'm dying, because I always believe I am dying. Every day the morning comes and I'm alive, I'm like, oh, I didn't die. Oh, okay. So it's a struggle. I largely feel like the doctors don't know what they're dealing with. And please, with all due respect to all the doctors on this panel, I feel like a lot still needs to be done. And Dr. Njagi, when you spoke about people saying the pain is in your head, I've heard that before. Like so many times, so many doctors, Kenya, Tanzania, have told me the pain is imagined. Like, so you think I've just woken up to leave my house at 2 a.m. to come and say, I've taken hyoscine, tramadol, and then now the amount of painkillers that you have to pump into your body, nobody tells you the other problems that all these pharmaceuticals you're putting through your system give birth to. It's crazy. And I don't know, and it feels like there's no cure. And I'm traumatized by all your slides. Ooh, people are suffering. So for me, hysterectomy cured the anemia. Now the endo is in my bowels. I only have my ovaries, which I wanted gone, but Posa, you said I can't remove them. I don't know why. But I'm just like, I don't want them because I feel like I'm constantly in pain. And I'm like, maybe if we removed everything, then the pain will go away. Yeah.
Kunywa maji. Take your water. Jackie, can you re-emphasize why she still needs her ovaries? Because
Well,
I'm over there, I'm the only one hanging between her and her ovaries.
see, again, as I mentioned earlier, and this is the most terrible option that patient get is they think by cutting off the influence of hormones, you're going to cure endometriosis, and that is a fallacy. Otherwise, there will be no endometriosis in postmenopausal patients. And we've had enough patients who have come without their ovary. There's a huge nodule in the bowel that was left in. This woman is now suffering issues of hot flashes, vaginal dryness. I mean, all the symptoms that goes along with removal of the ovaries. And then you still find, still with that, they're still having pain. The treatment of endometriosis, the management of endometriosis is whatever there's nodule or there's that endometriosis need to come out with or without the ovary. Ovary is not going to cure endometriosis. You need those ovaries. I would say, and you see, the challenge is that most patients, Becky, I can imagine. Because I've seen patients. I don't know how it is to leave a second of endometriosis, but I've seen patients coming to my office with IV lines, and they say I had to get morphine this morning so that I can make I can only imagine. I've had patients who have had their ovaries removed. They still have endometriosis, and they're still having this excruciating pain. What I think is important, the disease needs to come out. And I feel sad for you because the biggest challenges we have is having expertized care on management of endometriosis, which I think is the biggest problem that we have. Just because somebody does a laparoscopy, can put in a scope, it doesn't mean they can manage endometriosis. Unfortunately, and I'm saying this because I'm one of them, we doctors, we have this fat ego that we cannot come and tell you, you know what, I'm sorry, it was too much, I cannot do it. Because why? You've paid me the money and I was the hero here. There's no heroism about endometriosis. We need to come and tell, hey, look here, you have endometriosis in the bowel. You either need to have bowel resection, you need to have discoid excision. We have to find solution. And, there is, by having that an option, that the only option now that is remaining here is to remove your ovaries. I think it's terrible. And honestly, Becky, just to learn that you have bowel endometriosis, and this is every story, you have the first surgery, you have the second surgery, you have the third surgery. The option is to try as much as possible to get out as much disease as you can possibly do. It is not about hysterectomy or removing the ovary. Well, hysterectomy still is preserved for quotation like adenomyosis, but not endometriosis. If the uterus has no disease, it's not a culprit to be excised or to be removed. What needs to come out is the disease, period.
Okay, Vicky, Vicky, is your audio back? Let's see.
Can you hear me now?
Yes, we can hear you, but
Yes.
we can't see you.
So basically what I was adding is that, yes, we are talking about pain. And when we talk about pain, is that the pain affects the muscles. So it affects the nerves. And you find that the muscles go into hypertonicity, whereby they're just in a spasmodic mode. And most of the time, patients suffering from endometriosis will always report, oh, I have pain around the groin going down to my adductors, that is the inner thigh. I have pain on my back. I feel like something is thrusting my anal area. I feel like my mid-back cannot even stabilize. I'm constantly in pain, because we've learned that endometriosis can even affect the diaphragm, can affect the abdominal wall, and they are constantly in pain. So once these muscles are tight, they are in hypertonicity, in spasmodic mode, then we need to release them, because they always form trigger points. And those trigger points, until we work on them and train the patients on how to lengthen those muscles, because we take them through relaxation techniques which are meant for lengthening those muscles, and at the same time teach them on behavioral techniques. When it comes to the bladder, most of them will report urgency, frequency, and that is basically because the muscles, the pelvic floor muscles, are supporting definitely the bladder. So when they're in hypertonicity, they sort of like squeeze the bladder, and the bladder doesn't feel fully. So what happens? They keep on rushing to the toilet frequently. So this is where we come in as physiotherapists to try and train on behavioral techniques. We train on the bladder, we train on the bowel. The bowel, Becky has just talked about constipation. So we actually do so much of visceral release, so that at least we can make those intestines that's now functioning normally, even despite that they're given sometimes the diet, they're given medication to help and open the bowels. Then we want to take them back to the normal physiological process. And that's how we come in.
Oh, okay. Thank you very much. And I'm just wondering, in terms of misdiagnosis, I know the endo mimics other things, and I don't know, 10 or okay, 10, because you've been silent for a second over there. What are the great mimickers of what does and then you'll touch on the infertility, because you're our infertility person here. What does endo look like? What do people mistake it? And feel free to throw under the bus the gastro people.
Okay. I think endo one, it can be silent. To be honest, we've had even patients who have come for fertility. We're not understanding why they're not getting pregnant. And then you go in for a diagnostic laparoscopy and you see endo. And it's like what Jackie said, that there is no correlation between pain and the severity or the type of endo you have in terms of stage. And therefore, one thing that I'd like to clarify is endo can be silent. There's some patients who are lucky enough not to have any pain symptoms. Those are the lucky ones. However, endo is everywhere. So from Jackie's slides, you can take that as part of endo, but endo can appear as fatigue. Endo can appear as she said, gastro issues, dyspepsia, bloatedness, the rectal pain that you're not even understanding. Vicky talked about pain during menstruals just radiating down to your legs. So endo can be anything. Now, therefore, it can be confused for all those things. It can be confused for all those things. The other things that can cause pelvic pain are some other infections. So TB, inflammatory diseases that are in the pelvis can also cause pain, and that have maybe no indication or no association with endo.
Okay, and then touch on the infertility bit while you're here.
Infertility and endo is huge. Yeah? We do think that at least 50% of patients with endo will have infertility. Now, unfortunately, in Kenya and in our part of the world, we have no research because just until recently, we thought that it was a white man's disease, unfortunately. So we do not have studies showing what our population looks like, but I'm hoping Jackie and his team will do something for us soon. But in terms of infertility, it is huge. And I've said, as I've said, it could be silent. Someone just comes in for fertility treatment, and that's when we find endo. Or they say we have mild periods, and then that's when we find endo. So it is hugely associated with fertility issues, but it is not equal to infertility. And I want to stress this because I have patients who have been diagnosed with endo, and when they come in, we've done a transvaginal scans, their ovaries are really okay. There's no ovarian endometriosis called an endometrioma, but they're young and they're so scared that they want to start coming in to do IVF or oocyte preservation, like storing their eggs for later. And sometimes it's because of all the hype that is there that it is equal to infertility. It is not equal to infertility. There are lots of patients who conceive naturally and don't even know they have endo until maybe they've had their third child and something. But it is associated, but not equal.
Okay. I'm just thinking of my OBGYN days. Both your and where we did internship, both of us. People forget I'm a doctor sometimes. Anyway, but I'm just wondering that we were taught common things occur more commonly. And I don't remember if we ever learned about endo, as in the most, if we learned about endo, because we were just busy treating fibroids, cancers, fistulas, and then delivering babies left, right, center. You do a hysterectomy there. What's a training now like as in, am I able to just in good faith tell someone that, yeah, go see someone in Kenya, they're well trained right now, they can sort your endo? Have we changed the training around endo? Are we teaching it? I don't know. Kizungu imeisha hapo. Jagi,
can I speak? Because Jagi, I don't want Jagi to speak. I want to honor him because
okay.
Jagi just gotten an award or a recognition as one of the best. I mean, as the first endo surgeon.
Rusheni reactions at anyinyi watu.
Yes, so we are very, very, very proud of him. Yeah.
Flowers.
Yes,
Flowers.
many flowers.
Yes, yeah.
Many flowers. I just want to say one thing. When I trained for my infertility in Belgium, the center I was in Leuven was actually an endometriosis center. And what I noticed there, it is such a multifactorial disease. There's I'm liking that Vicky is on. There was a physiotherapist, there was a psychiatrist, there was a counselor, there's the endosurgeon, there's a bowel surgeon. They would go in, even for surgery, we'd have a bowel surgeon. It was a team that could do anything. Now, when I came back and started seeing endo patients, I was like, my goodness, you cannot do this alone. And I think Jaggi and his team have done a fantastic job to actually form a group that actually work together to ensure that you're doing good surgery. Because to be honest, Posa, if you get stage 4, where it's in the rectum and you are there in Nairobi, somewhere in a hospital, and you have no bowel surgeon, you will get stuck unless you have perfected your skill. And the thing about laparoscopy, it's a game of numbers. You cannot do one laparoscopic surgery today and then do another one in 3 months and become an expert. So I think that has hugely been lacking in our society, because everyone is a me person. So the better, I like how these guys work, because they work in a team. So you see more patients and you do many cases, and therefore you become an expert. I'm not an expert endosurgeon. I hope to one day be there, or maybe not, because I like my infertility bit very much. But I'd give kudos to Jaggi. He and his team. There's a group called LapMash, which is very, very on to this. And so we have grown. That is just my point. Now he can take over so that I don't.
Becky, there's hope.
Yeah.
A question, Posa, please, before the doctors come on. So I have a degenerative disc disease as well. And I have very bad sciatica nerve pain down my right foot. Is the pain getting worse because of the endo? Is that possible? Is that what I am hearing? That the pain really? So because my orthopedic and my gyna are constantly at loggerheads, so they keep bouncing you back. The ortho guys will say this is a gyne issue. The gynecologists are like, go back to orthopedic, and I'm like, you people, you people, you people. Is it related?
Well, I think, Becky, to answer your question, is that as you've seen, endometriosis has no boundaries. And this is where the problem comes, when it's difficult, who does it belong to? Me as a gynecologist is now making sense. Please go to the ortho. The ortho doesn't know endometriosis. So then ortho, go back to the gynecologist. And who gets to suffer in between? You're being tossed from one end up, exactly. Now, I just really want to say that we are making progress. And thank you so much, Dr. Ndegwa, for mentioning some of the milestones that we have made. It has been difficult. It has been pushing. It has been, there's a lot of backlash, I should say, for a fact. But it has been being resilient and persistent and just having an objective. What do we need from all this? And we've worked so hard. So, Becky, I just honestly want to tell you there's hope. Now, just to mention to you, we have seen endometriosis invading nerves, including the sciatic nerve. That is a possibility. I'm sorry, it could be sending us, kind of not really good news, but we have seen sciatic nerve endometriosis. The challenge we are finding is even with good MRI, they are not picking it up because they don't know it. We are having conversation. I was planning to have a meeting with the radiologist from SONA, because SONA is big, and say, hey, can we come together? Because the pelvic endometriosis, that we are picking it up because now we have started doing our own ultrasound scan. Because if I'm going to operate on a patient, I need to own what I found, not because Mr. So-and-so, who does, possibly doesn't appreciate much of endometriosis, doesn't tell me there's no endometriosis. And also currently we know, in the absence of evidence of endometriosis on ultrasound scan, if patient has symptoms suggestive of endometriosis, then you want to think of endometriosis. And that's why we say laparoscopy still remains the gold standard for the diagnosis of endometriosis. Unfortunately, if you have deep endometriosis, you cannot pick this endometriosis on laparoscopy, because how are you going to see below the surface? Because endometriosis is a disease which, what you only see is an iceberg. So could you be have we seen patients who have sciatic nerve endometriosis? The answer is yes. So if you're having this sciatica kind of pain, it's very important to have a good MRI. Again, don't ask me because I really don't know who is actually doing this imaging. I gotta be honest with you. But yes, we have found, now I'm telling you, some of the endometriosis we have found invading the pelvis is just, you sit back and you ask yourself, what in the world was this nodule thinking getting wherever it is? So it's a possibility. As long as you're having this pain, I think emphasis should be made to really do good imaging and try to figure out, could we be missing out something? Because as long as this pain is there, as long as you've had the PT after we have done our surgery and, they have taken you, the physiotherapy, everything is looking fine, the stretching and the relaxation of the pelvic muscle and so on, then if you're still constantly having this pain, which is specific for endometriosis, then you really need to figure it out. You need to look until you get the answers. So what has actually been the biggest challenge over the years is, and let me answer the question that was asked by, Dr. Ashwani. I think you finished medical school before some of us. When we finished medical school, we never heard about endometriosis. I don't think even for my postgraduate, I ever had a, topic on endometriosis. It was never there. We were never told about endometriosis. Today, I'm talking about today, because I still go back to the university where I trained from. They still don't talk about endometriosis. When we did the endometriosis marathon, we invited the head of department, Nairobi University. We invited the head of department, KU. We invited the head of department, Moi. And Professor Cheserem, she actually spoke, and she said it's actually very, very sad that even up to today, she's the head of department, even today, we are not talking about endometriosis. Can you imagine? In training institution, postgraduate people are being trained to become gynecologists. A condition that is affecting 10% of women in their reproductive age is still not being trained in residence. Honestly, I mean, it's a disaster. I mean, honestly, it's really a disaster. So then the question comes back, then what is some of our story with endometriosis? I think it's part of our mentorship, and I thank God for my mentor, because I had endometriosis with my mentor. But then again, endometriosis had knocked door in his own house. So it was something that was personal to him. And seeing the excitement and learning how difficult this condition was, then somebody had to do it. So over time, of course, we are talking about it. We have really, really worked hard to change the narrative. And at least today, most of us are talking about endometriosis. As much as we are still trying to figure out how to manage endometriosis, I can say that there's a lot of efforts that's being put towards endometriosis. And, Becky and the rest of us here, there's hope for endometriosis. Absolutely, absolutely.
I just also want to chip in and say that I think patients are actually taking a stand. And I do commend a lot of patients who have come up with their story. I mean, media has picked it up. And therefore, even as doctors, we have been made to, go back and say, okay, what is this endometriosis? Unfortunately, but I really, really want to commend the patients who have taken a stand and even started organizations. There are many small NGOs organizations for endo warriors in Kenya now, which is great.
You guys need to give me hope. As in, nimechoka na mimi si patient. I'm so tired. I almost muted and just went and did a sigalagala, like a whole whale out over there. But in terms of patients advocates, I saw Jambi Kokai because her she's no, is she called Jambi Kokai?
Yes,
yes. Yeah, and she was, at least I saw her at the University of Nairobi talking about teaching the OBGY residents about her lived experience, and she was talking about bowel endometriosis. So there's hope in that, but we need to just let's continue. I'm gonna moan for a few more days. So once you have these crazy pains, you're not getting pregnant, what are the steps? As in, how do we get, I know you've mentioned it, but so that the record stands, what are the steps? What do you actually do to get down to the diagnosis of endo?
Yeah, Jackie, you want to start with?
Okay. Yeah. So let me say a patient comes to me and this patient possibly has endometriosis. So the first thing we do is we're going to have a conversation. And what I found is very, very important for patients who have endometriosis. You have to listen to them. And for me is that they are going to be those sideline that is not important to the patient, that makes all the difference. So it's listen, what is your storyline? Again, as we've mentioned here, and Dr. Nego has mentioned, endometriosis sometimes is a silence. So you might have a patient who has lived this pain and gaslighting that, okay, this is normal. So it's normal for me to have painful menses. And they are there because they have done a test to check their fallopian tubes and their fallopian tube is blocked. And all that they are interested in finding out is how is their fallopian tube, when they have their fallopian tubes. So we have to listen. Listening has been very, very important to me. So now, if you gather information that this patient could have symptoms, or they have symptoms suggestive of endometriosis, then the first line on investigation that we have to do is a transvaginal ultrasound scan. Now, transvaginal ultrasound scan for endometriosis has to be performed by someone who has been trained on ultrasound scan for endometriosis, because in most of our training, we're trained on how to look at the uterus, the ovaries, and the bladder. If we see the uterus, the ovary, and the bladder, we are able to count fibroids and so on and so forth, and that's perfectly fine. So there are many things that we look for when we are performing ultrasound scan for endometriosis. Of course, we are going to look at these structures. Is there adenomyosis? Is there endometriosis of the ovary? But then we are going to see how is the relationship between these structures, the bladder, the uterus, and the bowel, and the ovary with each other. And then what we call the sliding sign. So what we do when, and the value of ultrasound scan is because it's a dynamic investigation. So what do I mean by dynamic examination is you are able to, in real time, be able to assess what is the mobility of the tissues. What is the, is there, I mean, a tissue stuck to each other, because that can be the only significant finding when you perform ultrasound scan. So we check for the sliding sign, we check for possible nodules, we see how is the rectum looking like, is there, because for us, we know what is the commonest place that we are going to look for endometriosis, which is going to be below the uterus at the level of the cervix and the uterus, what we call the torus uterinus, and the uterosacral ligament. So these are going to be the most places that we are going to look for changes that are suggestive of endometriosis. Now, when we find these changes, then we are going to, again, relate this to the patient's symptoms. And that's where we are going to plan what is going to be the option of treatment for the patient. And option of treatment, there are quite numerous options of treatment. Now, in the event that we find that there's no evidence of endometriosis from ultrasound scan, but the patient still has symptoms suggestive of endometriosis, we don't rule out endometriosis just because we are not able to pick it up. So we'll tell the patient, your symptoms are suggestive of endometriosis, but our ultrasound scan findings, they are not suggestive of endometriosis. So that can mean the following. You either don't have endometriosis or you have early stage of endometriosis. Again, remember I mentioned that what we have found, there's no correlation between the stage of endometriosis and the patient's symptoms. So then you'll discuss with the patient and you say, okay, fine. What is the period you've had your symptoms? Is it justifiable for us to start your treatment? So we can start patient on treatment for about a period of 3 months. We see how they are going to respond as they prepare themselves, that in the event that things are not going to get better, we could possibly going to do laparoscopy. So then the next step, we will perform laparoscopy for patients that we have not seen any changes. And in most cases, we are going to find changes that are of endometriosis of nature. And these are changes that even skilled laparoscopic surgeons have actually missed. What is this? Suggestive of any form of inflammation. It's something that we call pseudopouching. We can see what look like gunpowder. So there are different things that we look at. We have imaging system that we can change the color, which we call it narrow band imaging, and then we are able to see the changes that is suggestive of endometriosis. So then from there, we are going to decide on the treatment. Now, in the event that we do ultrasound scan and we find that there are obvious nodules, they are on the bowel, there's endometrioma, we will need to sit and talk to the patient because we have found medical treatment might not be feasible for this patient. So we're going to have a lot of conversation. What is your plan for fertility? So now me and Dr. Ndegwa, we are going to sit and plan. What is the plan for this patient? Do we think she can conceive naturally? Is it going to be IVF? Because now we need to plan the treatment. For instance, just as I mentioned, if the patient has endometrioma, we know that her fertility is going to be greatly affected. And in the event I am going to perform surgery and do the cystectomy or remove the endometrium, is going to greatly affect her fertility. So we need to have this conversation. And that's the reason we started by saying endometriosis, it doesn't matter how of a good surgeon I could be. It's not a one-man show. It has to be a multidisciplinary team. Now, there are different definitions when you talk about team. Do you talk about team in terms of skill, or do you talk about team in terms of, that's different depending on where we are working in different locations. But for patients who desire fertility, there should be candid conversation between the surgeon, who will be myself, and the fertility specialist, Dr. Ndegwa, the patient being in the middle. In some cases, I've had to delay my surgery. The patient goes to the fertility specialist, they have their ovum pickup done, then it's stored, then I can come and perform my surgery. So there are different options of take in terms of what we find. But ultrasound scan should be the first line of investigation. We have seen now there's not much added value for MRI. MRI is going to miss pelvic endometriosis for sure, unless now you have, let's say, nodule involving the nerves, which we cannot do on ultrasound scan, or you have diaphragmatic endometriosis, or you have upper GI endometriosis. But in most cases, MRI really doesn't have added value. In the event that now we don't pick up endometriosis, we can start patient on treatment for a period of time. If they're still not getting better, laparoscopy.
Yeah.
Okay, Wanjiru.
Yeah, so Posa, in terms of, thanks, Jackie, because he's gone through it very well. This is a patient who presents and has pain. And the question that really needs to be asked about that to that patient is, are you seeking fertility as well? And I know a lot of patients have come to me and said, well, I've come for pain, you're now telling me about fertility, but and I tell them it's a very important question. And I really want to share this, because at the end of the day, we've had a lot of patients we do understand the pain, and I do not take it away from you, Becky, and everyone else who suffers from endo. But it is, I always say, it would be such a pity to focus on the pain, which we are focusing on, and nobody have told you that later on you may not be able to conceive, if especially someone goes in and removes cis endometriomas, just like what Jackie was saying, and we've seen this. Someone comes in and they say, I've had surgery on my ovaries thrice, and I look and I'm like this, because that means the ovary that is left is very small. The chance that we have oocytes or eggs that are going to help us get pregnant are not there. And yet that patient was just going in for pain, and sometimes nobody ever asked her that question. And therefore, for me, I think the one thing that I like that Jackie brought up is that, what does your future look like? Yes, this is endo, but what do you want? Is it yeah. So for the fertility aspect, before I deviate too much, because these are the questions I get faced with a lot, is that we look at many things before we decide if you're coming in for fertility and you have endo. One is your age, because age is everything for fertility. Yeah? You're a 45-year-old and a 25-year-old are worlds apart in terms of quality of eggs, despite their endo. And so number one is age. Now, the other thing that we are looking at when you come into my office and say I have infertility and I have endo is, how long have I been having this fertility? Did I get married 3 months ago? Did I get married 6 years ago? So if you're a patient who has had infertility for a long time, or who has been struggling to conceive for like 6 years, then we are very different than a patient who has been trying to conceive for like 3 months. Now, the other thing is, what is your stage of endo? What stage are we on? Are we in stage 4, where it's in the pelvis, it's in the rectum, it's infiltrated in many other areas, or are we in stage 1, where it's minimal? There's minimal implants in the womb or in the pelvis. So these things must be factored in before we decide, okay, are we going to allow you just to conceive naturally and, do probably a few like ovulation induction, if that's the second phase, or are we then going to do an intrauterine insemination, or are we going to do IVF? So there are very many things that we would take. So it's what Jackie was saying. We have to take a thorough history. We have to listen to the patient, but we have to take everybody as an individual. It's not a blanket that you'll come in and I say IVF. It's not a blanket that you'll come in and I say, just go and conceive naturally. It is very important to take the whole patient and even the spouse. Remember, the spouse comes in because are sperm normal, or do we have sperm issues? So it's a very, very individual treatment for each and every patient. But guidelines are stage 1 and 2, we can do a lot, and a younger age. But when the patient now starts getting older, someone who comes in at 40 probably, or 42 or something like that, and in fact over 35, and you have stage 4 endo, really we now start thinking IVF is your solution. And that's just because we want to give you the best chance as early as possible. Not wait. You came to see me at 30. We've been doing ovulation induction. This is trying to help you to ovulate for 10 years. And then at 40, really, I've wasted your time.
I'm just going to share my screen because someone has asked about the gunpowder appearance, and Becky, it might be triggering, so maybe toka kidogo. Jackie, can you just in the famous words of whatever, can you all see my? Yeah. Is that the I've just Googled it because I had never seen gunpowder. This is too much?
Well, yeah. No, it's
okay,
not.
do you have a better image?
Let me just see if I can get one.
Okay. Carol Mutai, Dr. Njagi is looking for a better image on gunpowder. And if someone could answer the questions, I've already told Saya men don't get endometriosis because they don't have endometrial tissue. This is just me being rude to my brother, but I think that's the answer. And then can you have both fibroids and endo? I think you can have, endo is just the devil. You can have it with anything else.
Actually, you can, because I've responded to the person who asked. It's like, for me, I had fibroids, I had ovarian cysts, and it was an entire mess in that uterus. It was not appealing.
Okay, as I'm thinking, so the people with sickle cell, so you get sickle cell crisis, then someone throws in endo. I'm going to, maybe I'll need some moments after this. I'm feeling pain for everyone. Poleni sana. Sharon, go ahead. Ask your question.
Okay, so the other one I'd wanted to ask is there any chance the myoma an endometrioma will present or look like a myoma when, the doctor is observing it? I don't know if I'm using the right terms here, but it's just, is there any chance that one could be confused for the other? Like you go in and they do an ultrasound and then they tell you what you have is a myoma, or myomas, like I'm guessing that's the medical term for fibroids, but essentially it's an endometrioma. Is there any chance someone could like mix up the two?
Well, I think let me first share the image I found and then I'll answer your question. So when you talk of endometriosis, there endometrioma, adenomyosis, endometriosis, and fibroids are different. So remember when I was, and God, I wish I can get a few images here of an adenomyosis. Let me share my slide here, and where is this? So you can see my page, right?
Yes.
Okay, so let me explain the differences in all this. I don't have a better image here. So if you look at this image here, this is a normal. This side is a normal uterine muscle layer, and then when we have adenomyosis, is a form of endometriosis, but this time you have the endometrial-like tissue growing within the myometrium. Now, this is different from endometriosis. Can you have adenomyosis and endometriosis? Absolutely, yes. What we're actually finding is that adenomyosis and endometriosis are two twins that live together. So you can have these two together. Now, the question you ask, can adenomyosis and endometriosis be confused? In most cases, yes, we have had adenomyosis confused because adenomyosis can either what we call focal adenomyosis or diffuse adenomyosis. So when you have diffuse focal adenomyosis, it's going to be confined at one region, and it has kind of similarities with fibroids. But in a good eye, you cannot miss adenomyosis because in most cases, the fibroid has very good margins. And then when we are looking at it, there are different changes that we look at when we are doing ultrasound scan that can be able to tell us if there's difference between adenomyosis or adenomyosis or fibroid. Now, in cases where you have diffuse adenomyosis, it's whereby in most cases, the entire uterine fibroid has possibly been invaded by this tissue, which are of similar to the endometrium. Now, what is endometrioma? Therefore, endometrioma is when you have the ovary has been, and is the image that I showed initially. So you have the ovary now has endometriosis, or that's this tissue. So in most cases, what happened? What we have found is going to be on the surface of the ovary. You'll have this overgrowth of the tissue, but during the development, you're going to have the invagination, or the surface is going to fold inside, and then because of the inflammation, then over time, since remember we said the same reaction that happens on the lining of the uterus, the same thing will happen to this tissue. So this tissue will keep menstruating, but the blood will not flow out or will not be released. So over time, you will find that the cyst or the ovary will keep growing bigger in size. And this is what I had showed initially. And, over time, you have this content accumulating. And this is the reason why endometrioma is called a chocolate cyst, because the content that is inside looks like chocolate. What is it looks like chocolate is because it's old blood that has been collected there for years, and this greatly affect fertility. So two conditions we find that affecting fertility. Number one is adenomyosis, and we feel that adenomyosis is, even in terms of fertility, it's worse than endometriosis. And also endometrioma can also have significant effect on fertility. Fibroid, I think I've mentioned. And what else was it? I think that was about it.
The gunpowder image, a better one than
okay, the gunpowder image. So again, this is not mostly for the patient to really tell, is mostly for us surgeons. It looks something like this. Okay, I hope you can all see my slide.
Actually, Jackie, one of your presentations had. There was what
yes, there's the one that had, but that was more of an endometriosis nodule. There is, and I saw that, I wanted to show that, but that was very obvious. Now, this is what this is what is not very obvious for most of us who do laparoscopy. The moment I see this scarring here, this is suggestive of endometriosis. When I see this scarring here, this is suggestive of endometriosis. The moment I see this reddening on behind the uterus here and around here, this is typical suggestive of endometriosis. And this is what gets missed out a lot, because what most people feel is when they do laparoscopy, they are going to find that nodule that I showed initially, and what they miss are these changes that are suggestive of endometriosis. And this is where now the question, how do you manage this when you do laparoscopy? I saw someone asking, Is there excision surgery being performed? I think that's another big question. So what we do in this case, I will definitely have to strip off. All this lining has to be stripped off. And that's where we talk about the difference between ablation and excision. Because all this tissue, ablation is where you come and you just burn on top of here, but you don't know how much of the disease is below what you can see. Because we know endometriosis, what you see is just an iceberg. Most of the disease is lying behind it. So this is the very typical changes of endometriosis, because there's this chronic inflammation that is going on this tissue. So the question you ask yourself, why is this tissue not similar to this? Because this is the normal tissue here. Why is this tissue not, different? And when we strip off all this tissue, we send it for histology, the diagnosis comes back as endometriosis.
Okay.
Also, just before you move on, just because a doctor has said this part, the question is excision surgery now being performed in Kenya? Is it available in Kenya? And a second question, not related to that, is maybe I know you probably segue to myths and truths, but one of the questions is, does using menstrual cups have any bearing on the whole endometriosis situation? Two questions.
We'll hold the menstrual cup to the myths and truths later, but you can touch on the excision. And someone else has asked if calcified fibroids can be confused for adenomyosis. Yes.
Dr. Ndegwa, maybe you want to. I think the excision. Let me answer the excision one. There's been a huge misconception here, and this is part where I feel sad. And Dr. Ashwani, I think you mentioned it. There's still a lot of advocacy that is locally going on whereby this surgery has not performed in Kenya. And I feel it's a little bit sad for ourselves. And that's why we still find patients. And I'm saying this because I've had normal patients, even in some of the advocacy group, which actually they're still saying, oh, there's no excision done in Kenya. You need to go to Romania. You need to go to India. You need to go to all these places. I want to say all these procedures have actually been performed recently. I am not the first guy who's coming to perform excision surgery. There's a lot of endometriosis which has actually been performed even before I started performing laparoscopy. It has been performed. The question is, to who do you go to and who does what? But to say that excision surgery has not been available in Kenya, it's not fair, and it's not the true concept. Of course, there's a lot that we are learning about endometriosis. And now, again, you see what's going on is patients are now really smart. They are going on Google, and they're Googling and say ablation and excision. And now what looks like is like excision is just a magic thing. Excision just means just cutting out that part. What I've just mentioned, I would say removing a hysterectomy laparoscopically could be difficult, which hysterectomy has been performed for more than 20 years since laparoscopy was introduced into this, into this country. So excision, what it just mean, what I was just showing, there's a small nodule here. You just cut it out and remove. How can that be difficult, honestly? But having said that, I have shown you the different stages of disease. So even when you cut off the endometriosis in the bowel, it's excision. When you cut that small peritoneum, is excision. So excision for peritoneal endometriosis is definitely more difficult from excision of the endometriosis in the diaphragm or in the rectum. So just to put a blanket that excision is, no, it's not the same. The more advanced disease, even for some of us who are doing advanced disease, doesn't matter excision or. So I'm finding a point whereby you are getting a little bit of the excited patient comes to your office. Do you perform excision surgery? And I'm like, okay, I think you're Googling so much. So the patient does not even know how much disease they have. They have no idea. But they come to us and they feel that to test Dr. Njagi to see if he's the guy or he's not the guy, do you perform excision surgery? I'm like, do you even know what you're really talking about? So, and I mean now, even when I don't know how to perform excision, you ask, yes, I perform excision surgery. But the complexity of the surgery depends on the stage of the disease. So in simple words, excision surgery has been performed in this country for so many years.
I think the thing with Google Medicine and TikTok Medicine is that even when I was researching on endo, there are a lot of doctors who are just stamping out there, even in the US where we currently live. Management of endometriosis is a nightmare. It's not like the general OBGYNs can't do it, and the primary care physicians can't do it. And there are very few, the specialists are not that many. It's not even board certified for very many, you know, like the way oncology is board certified, they are still fighting to have board certification for for endo. And as the nature of all medical things, it's been kept. So the people who the people who preceded want to get kept because it's bread and butter. I need to have my yacht and I need to go to a holiday in Hawaii. So it's still being kept. So be careful. This is to the patients out there. Be very careful. Vet your sources and always have, you know, the side medic. You can always ask, what's up? Do I need to do this? Always have a lawyer, a policeman, a watchman, and a doctor in your pocket that you can talk to as a Kenyan and as any other person.
Yeah, I'd just like to add what Dr. Njagi and Dr. Aswani. I can't remember when is the last time I called you that. But
it's Njagi who's over here spoiling me.
But I do think it's as the thing about endo is what you've said. It's a nightmare. If you go into stage 4 and you are not prepared, my friend, I mean, everything is stuck together. And removing that sometimes, if you've not done a scan, and that's why a vaginal scan the knowledge of what you're going into before you go into endosurgery is very important, because then you should map out your surgery and be aware of what you're doing. And I think what patients in Kenya don't know is that it sometimes has to be multidisciplinary. I know, Njagi, sometimes you still call a surgeon, because rarely, maybe rarely now, but I mean, a lot of us would still call a surgeon, because if it goes into the bowel, you would need somebody to return it. So that's the thing, that endo can go anywhere. So saying that it's endo is not even specifically a gynecological surgical issue. It could go to the lungs. Am I going to go to the lungs and remove endo? I'm not. So that's the thing about endo. And I want to just caution about even going outside. I've had patients who go outside and come back with colostomies, just because they had this place was great. So endo, even in the best of centers, can complicate. So I think the most important thing is, has the surgeon that you're going to do done thorough assessment of what your endo looks like, and therefore is properly prepared before he goes in. I think for me, preparation is key to everything. There was a question about a fibroid being confused with an endometrioma.
A calcified fibroid.
A calcified or degenerating myoma. I would say that scans are observer dependent, and I don't want to issues here, because I don't know if somebody is trying to find out if somebody did this. But I mean, if you do have a degenerative myoma, a small one that's maybe pedunculated means outside, and you have a frozen pelvis, and so everything is stuck together, you could maybe confuse it. So it depends on the situation. It's not a very easy thing to confuse, but if the fibroid is shooting out of the uterus, probably close to the ovary, has a degenerative change where it's not very easy to confuse it if you have done this for a long time, but you could. So observer dependence, it's against expertise as well.
Okay. Before we go to the physio, and I know there's a surgical bias here. What's the medical treatment for endo? If you're not cutting, what are you giving?
Me, Jackie or me?
You can start. You're the one on my screen.
So I think for medical management, and medical management is where also you do not want fertility, you want just pain management. It's what Jackie was talking about. There are a lot of progestins, so you can start with just progesterones. You can start with cyclic. There's Dynogest is there, right? We still use it. You can use GnRH agonist, but it depends now on the side effects of the patients. And some patients even do well with a Mirena IUCD. So there are very many, mostly we try and use progesterone based medication, or we shut down your system completely so that you're not ovulating. And if you're not ovulating, then you do not then have the pain.
Okay, and I don't know. Well, I tried to get a pain specialist, but would you touch on the hyperalgesia, as in like that comes with endometriosis, like the pain is out of this world. I don't know. I know it's not your specialty, but if you could just touch on it.
Actually, I've referred patients to pain anesthetists who are pain management specialists, because sometimes, I mean, someone is constantly in an emergency room getting diclofenac or getting, I mean, it's not even good for your gut. It's not. So there are patients who we've had to go and they actually get relief from pain anesthesiologists. There are specialists right now who do that.
Okay, and if you could just give us names, because I don't, the ones I have talked to are not responsive. Tell them I don't bite.
There's one I'll write the name here.
Okay, Jackie, on the pain aspect or the medical aspect.
Yeah. I still say that this is before we really say. I just as Dr. Ndego has mentioned, I've also had a couple of patients I've had to send to our team, because in our MDT team, we also have special pain specialists. You need to first rule out endometriosis. It really doesn't matter what block that you're going to give, what nerve you're going. Once that medication is going to still find endometriosis waiting for it again. And we know because of the inflammation that is going on. We also know that there's more irritability of the nerve. There could be nerve involvement. There could be more pain receptors for the nerve. So also the concept of the pain in endometriosis is quite diverse. So we don't always restrain it to being nerve in origin. It can be from adhesion, the stretching, and so on, and inflammation. So before we actually, and this is where I found patients who have gone and they have had incomplete excision of the nodule. You know, I've had a patient and which had excision surgery, and fortunately she had her recording, and I really want to say how sometimes it can get really bad. And the initial surgery, you could see the disease was well confined on the peritoneum. But when I saw the surgery, the whole time, you know, I was just holding myself, because you could really see how incomplete the surgery was performed. And now here you have completely distorted. Now it's going to heal with scarring. The tissue is going to invade even more because it's not restrained. And then a few months later, she comes back with this excruciating pain, and she had a huge nodule now, which could have been excised completely, encasing the ureter. Now, unfortunately, just to cut the story short, this patient has to keep a ureteric stent for a whole year. just because the ureter was so inflamed when we were excising of the disease, and the scarring was extremely terrible. Now, why am I saying this, or why am I bringing this? Is because sometimes we could perform and tell you we have completed the excision of the disease, and we have performed incomplete excision, and now we send you to the pain specialist, and the much they are going to do is to give you a block. And once they give you a block, this disease is still there. It doesn't really matter. And this is going back to recap on what Dr. Ndegwa was mentioning. At what point do we initiate medical treatment, and for how long are we giving medical treatment? You are giving patient the GnRH, which is going to put the patient on medical menopause. But for how long? You can only give this medication for 6 months or for up to about a year with add-back therapy. But you have not done anything to the nodule. The nodule is not going anywhere. So why are you really giving this GnRH agonist? Why are you giving these contraceptives? You don't even know the stage of the disease. And this is where we say, we first have to stage the disease. And if you find, listen, ladies and gentlemen, if you have a nodule that is more than 3 or 4 centimeters, it does not matter even if you baptize that patient with progestin, you baptize that patient with GnRH agonist, it's not going to do anything to that nodule. The moment that patient get off the treatment, they'll come back, the nodule is going to wait for them again and is going to cane them. And that's the reason why patient go get pregnant. But because their disease is still early stage of disease, it does not affect their fertility. You'll have an 18-year-old go get pregnant, and then they conceive, they come back, 3-6 months down the line, that pain comes back. Why? Because the treatment that if we give them progestin, we are putting this patient on pregnancy state. If we give them GnRH, we are putting this patient on menopause state. So these are the 2 options of treatment that we have, and the painkillers, which we know painkiller don't do anything to the endometriosis whatsoever under our circumstances. So you have patients who are going to even start injecting themselves with morphine, but they are not doing anything to the endometriosis. They guess us. You guys have crazy stories. So I have a patient. It came to my office this Friday. So this patient had been taken on this gaslight. She has no endometriosis and so on. So she was actually getting the injectable tramadol injectable. So she had to inject her. She told me I was even trained on how to inject myself. So she came in, we do the ultrasound scan, and she had the world endometriosis I had seen with a huge nodule that was involving her nerves on the left side. But because of the consequences that we get so I had to sacrifice the nerves on one side, the other side we could not sacrifice. So she goes back, she has her first menses, she still continues to inject her morphine because she doesn't, her tramadol, because she does not know what's going to happen. So when she had her first menses, she tells me it was the best menses I've ever had. So what does she decide? She decided to completely take off herself from tramadol. Guess what happens? She gets 3 conversions. 3 conversions. And if you guys think I'm kidding, I can hook her up. She gets 3 conversions. Now she goes back to the physician and said, you've been taking tramadol and you had this, complete stoppage of, so you have to taper down. So she started being tapered slowly. So that's the reason why we say the medical treatment is only reserved for special cases. The pain blocks is only reserved for only special cases. Because you got to ask yourself, what are you blocking? And for how long are you keep going to block? If you're giving medical treatment, the Dynogest, for how long are you going to give this medication and for what reason? Now, I saw a question. Do you give Dynogest? Yes, sometimes you give Dynogest because we know that we don't do anything to endometriosis. We don't cure endometriosis. And the development of endometriosis, we've not done anything even after we have done good excision. So what, therefore, are we doing? We are suppressing the disease because in most cases, endometriosis might recur. So it's not cure for endometriosis, and we don't know cure for endometriosis. And this is the saddest thing about endometriosis, but we can manage endometriosis and we can suppress endometriosis. So for me, if I have extensive disease, okay, sorry, Becky, I'm going to come to you. I know this is burning you like crazy here. So when I have excision and I see this was excision and the patient does not have fertility desire following my surgery, We can have a conversation. Do you want us to suppress you on some hormonal treatment? We can put patient on COC for as long as they can tolerate COC. But even with that, we are going to have regular follow-up. How is your pain? How is your quality of life? Has your plan for fertility changed over time? So it's not that it's going to be a blanket where now I put your medical, that is what you're going to be on forever. So we have to keep evaluating. Has anything changed? Because we know completely, we don't do anything to endometriosis. And that's why the cure for endometriosis, it is not there. So let nobody tell you they have cured endometriosis by taking to the operating theater under our circumstances.
Becky,
Yeah,
kunywa maji alafu kuje, because this is just you.
You've seen Posa.
Yeah,
Are you understanding? Are you?
Yeah.
I think now, because we are having this talk, Posa, you're beginning to understand why I am dying, and then everybody thinks I am not dying. Jesus Christ, what am I dealing with? Dr. Njagi, what are you telling me? So now, post so what happened is when they took out, when they did the hysterectomy last year, they left a part of the cervix. It was the part that was left behind by my primary gyne. We are doing speculation now because my primary gynecologist is in Mwanza. I'm currently in Dar es Salaam. But the speculation is that it was he couldn't go around the endo to take it out. And I think also at that point, I was severely anemic. So he was also dealing with the issue of me bleeding too much on the table. So well, he left it there. And then a lot of things have happened with my cervix and me nagging for, do you ever sleep though? Because I'm always in that inbox saying the morning will not come. So they took out the part of the cervix that was left, and then they see the endo, it's still in the bowels and all that. And so they say we begin leuprolide. What are you telling me, Dr. Njagi? That even with the leuprolide, you ni takataka. Like, I'm so tired because at this point, please note that I have to take pain medication both for the degenerative disc disease and for endo pain. I'm even embarrassed. I'm embarrassed to line my pain meds here because I look like an addict. I'm on aceclofenac, tramadol, baclofen, pregabalin, and now suppositories. They don't work. Do you know those things don't work? Those things are not working. Even as I'm sitting here, I'm sipping my water. What I actually want to do is to cry because of pain. But then I'm saying, okay, a day at a time. And I'm so tired of people telling me it gets better. What do you know about endo for you to tell me it gets better? No, it doesn't get better. No, I'm not feeling better. So what are you telling me, Dr. Njagi, that even the leuprolide that they put me on and we started, like it's rubbish? What are we saying?
Well, no, Becky, I totally understand, and I'm really sorry. What I am actually categorically stating, and this is because I really don't know what the stage of the disease is if you have a nodule on the rectum, rupride or GnRH agonists don't do anything to the nodule. Because remember, I just want, okay, it's important for us to go back, and I'm really sorry, I'm extremely sorry, Becky, and for the rest of us who are here listening to what's going on here. Remember, what we've said is that when this nodule has developed, all that you're doing with the leuprolide is you're suppressing the brain from producing hormones that are going to stimulate the ovary, that is going to stimulate the estrogen. That's all that you're doing. You're not doing anything to the nodule whatsoever. So if there was nodule, the moment, and how long are you going to be on leuprolide? You're going to be on leuprolide for a maximum of 6 months. And the maximum you can do is with add back therapy, but for how long are you actually going to be on suppression? So I don't know about your condition, but if there's nodule, the treatment of endometriotic nodule is excision. It has to come out. And leuprolide, medical treatment, does not mysteriously dissolve the nodule. That is categorical. The second thing that we also know, and I think this is for all of us, the only time we say there's indication of the removal of the uterus is not when patient has endometriosis. Of course, there are different studies which has suggested that by removal of the uterus, you reduce the chances of recurrence. But we also know that there's no indication of hysterectomy in the event that there's no adenomyosis. So the only time you have indication of hysterectomy if there's adenomyosis. Unfortunately, if you're performing hysterectomy because of adenomyosis, the cervix as well need to come out. Because we have actually seen in circumstances whereby, remember also the cervix is a continuation of the uterus. So if you're going to leave any adenomyosis on the cervix, then you have actually not done anything there. So the patient is going to have some relief of symptoms. And then also we know that this cervix, if it has adenomyosis, is sitting right next to the rectum. So we know that there's a risk of invasion of the bowel in the coming years. So if you now say there was bowel endometriosis, that means that you had advanced disease and there's still endometriosis. I'm just saying from your statement, there's possibly endometriosis that was left behind. So the adenomyosis, the leuprolide is usually medication that left out when we have felt that our hands are tied.
So Posa was right.
I don't know, Dr. Ndegwa.
They don't know what they're doing.
No.
They're just playing.
No. We've not said we don't. I want to just clarify that endo is chronic. I'm sorry, Becky, but endo is chronic. And therefore, when I was in Belgium, I think for me it was mind-boggling because I'd see a 12-year-old coming in, and I know I saw a woman who she was having her 6th surgery, laparoscopic, because it kept, you can remove nodules, they'll come back, remove nodules, you'll come back. So the thing about endo is to get an endo specialist. And I think that's the most important thing.
Correct.
To get someone who will walk with you the journey.
Understands, yeah.
Pride has its place. Dynogest has its place. COCs have their place. It is just when do you take what? And I think what Jag is trying to emphasize is even if there is a nodule that looks like this, even if I give you how many painkillers, it's not going to shrink, which
absolutely,
I think that's the thinking of people that, okay, or that it's going to go away. It's not going to go away. So we sympathize with you because we wouldn't want this on I don't know, my worst enemy. Endo is one of those diseases you just, I see patients and you just feel like your heart is, but it's not that people don't. I think sometimes people get stuck and are just like, how do I help you? You've had surgery 2 years ago. Do I take you in now? Do I give you some pain reliefs? Do I give you leuprolide for a while so that, before we go back in and do again major surgery? So it's a step-by-step process for endo.
And I think it calls for humility on we medics. We were number 1 in school, and I went to Alliance, or I went to Kawangware Secondary, has really screwed up our patients. The humility will change a lot because before, the decision not to cut is the most important decision. This, when you see a knife-happy surgeon, be afraid. Be very afraid. The decision not to cut is the most important one. And being humble enough to say, this is beyond me, I'll refer you to a proper specialist, is important. And I think we medics with our egos need, notice there, I've taken back my medic hat. We need to acknowledge that. Okay, let's go to Vicky and see if she has hope. Vicky kuja, njoo dada. Okay,
I'm here, Swani. I'm here.
Okay, so what do you do for the endo patients? I know it's late in Kenya, but this conversation, my God. Okay, what do you do for the endo patients, or the ones you get?
So let me say the first thing I want to appreciate Dr. Njagi because of embracing the multidisciplinary approach. During the Endo Marathon, I think it was a whole team. We had even psychologists, nutritionists, physiotherapists, surgeons. It was a whole team. And I think that's very credible that because there is no one line which you can say actually treats endo. It has to be a multidisciplinary approach. So my role here, you find that definitely we say that it mostly affects the physical bit. And if it is the diaphragm, basically because of the pain, so what the first approach we do, it's actually to train the patients on the breathing patterns, because you find that it's like the rib cage gets stuck, the pelvic muscles get stuck, the abdominal wall gets stuck. They have done surgery, and of course there is interference with those tissues. So you want to actually start training the patients from the word go on how to do in abdominal breathing exercises to stretch those tissues. So that is usually the first role we play. And then number two, we also train the patients on how to relax their pelvic floor muscles. There are certain techniques, poses, which mostly we call them child pose positions, which we train them on how to actually breathe in as they involve their pelvic floor muscles. You realize most of the time people do breathing patterns wrongly. And instead of then expanding their abdominal wall, when you're breathing in, it's like when you're putting air in a balloon is supposed to expand and it's not supposed to collapse. So we actually train them that when you breathe in, you're supposed to expand the wall like a balloon, and that should involve also your pelvic floor muscles. And then number two, basically what we train on is positions. Posture is interfered with so much during this time when they're going through pain. Most of them tend to coil, and that affects the paraspinal muscles, it affects the quadratus lumborum, it affects the pelvic muscles, and so most of them, they will also get what we call pelvic tilts. So we teach them on postural correction. And then number three, also what we do is pressure management. Pressure management, most of the patients, you'll find that when they're in pain, they coil. After surgery, they're in pain. They don't want even to know how to bed out, to get out of the bed. And so we teach them on how to do proper techniques when it comes to pressure management. We also work on manual techniques, which we actually release those trigger points. We release the myofascial layer, which basically gets stuck because of the pain. And this one, we do it externally and also we do it internally. And most of the patients with endometriosis, they, like I said, they have tight muscles because of hypertonicity, muscle guarding. So you find that that's why most of them will tell you also they have pain during sex. And so you get in, and even we do internal release and train them on how to strengthen those muscles. Positions during defecation, when they go for bowel movements, it's very important because most of these patients, they get constipation. And then when they go to the toilet, what they do, they want to push. And that's wrong. That actually gives them more strain, and it can also actually cause hemorrhoids. So we train them on how to do proper defecation when they get to the toilet. We also give them bladder diary, which they are able to follow when they are emptying. They're going to pee, so that they make sure that they start training their bladder on how to function normally, because a normal bladder should be able to empty between 2 to 4 hours. So we also give them a bladder diary so that they are able to know what to do. So those are some of the approaches which we do, and we train the patients so that at least we can make sure that all of them, they achieve good results. Pudendal neuralgias are very common with patients with endometriosis for surgery. That's why most of them will tell you, I have pain running along the sciatic nerve. Yes, the doctor will go in, release, but the symptoms will still remain there. So we could do what we call, others will tell you they have pain, which is coming to their clitoris, to their vulvar region. And of course, we really work on that. We call it nerve floss, where we stretch it and we train them on how to do those stretches so that they can release the tension in the nerve.
Thank
you.
And because we are Kenyans, we have to talk about herbal remedies and diet. Is anything working, or people are just selling us hot air? And this is up to everyone on this panel.
Hot air.
Okay. Becky, kaa uko na wet blanket yako, wacha nitafute watu wengine. Wanjiro and Dr. Njagi and Victor and Vicky, is it hot air or the herbal remedies are really working?
Jackie, someone else start.
I honestly, I don't know. You see, it's difficult to really tell if there's anything is working there, because endometriosis, again, as we are putting it, is such a difficult condition to manage. So I'll be very, very happy to find something that will sort out an endometriosis stage 2, stage 3, stage 4. What I think is hot air, because someone I don't know how many of you watched this show, and I started by talking about it when I started The View. She's called Goldberg. What's her name? Whoopi Goldberg. And please, if you didn't, just go look at it. And she was on media saying, "Oh, I had endometriosis, and for a very long time, nobody knew what was going on. And I saw the doctor, and he made a diagnosis, and I had lived this excruciating life. I was discharging stuff through my vagina, and then they gave me antibiotics." So Whoopi Goldberg feels that her endometriosis was treated by antibiotics. And she goes on a talk show and she said, I had endometriosis that was treated by antibiotics. So can you imagine? I mean, what kind of nonsense, honestly, is that? I mean, it's terrible. It's really terrible. So I know patients.
Even acupuncture, nothing is working.
So I honestly have very little experience, and I'm really biased because I'm a surgeon. But if you want me to be very honest, I doubt if you have that advanced endometriosis. Well, honestly, I have very little experience, and this, as you mentioned, this is Kenya, so.
Okay, yeah. Wanjiro, because we have a bit of calluses in the medical field. Have you seen anything working? No. There is no hope, surely.
I don't even want to talk about the most common one, but I'm telling you, I've seen all manner of people coming and saying it is treating their fibroids, they're shrinking, this endo is getting smaller. I don't believe in it, but again, we are biased, we are scientists, we need to actually see what ingredients are in these herbal concoctions, which we do not know. So mitishamba.
Vicky, I'm having hope on your side.
There is no hope, for sure.
Okay.
It is the same. It's basically business, let me say that. And most of it, of course, there are others who will talk about it because they want to sell. But the truth is, there is no cure with those concoctions.
Okay.
Posa, I speak as somebody who has drank those concoctions.
Okay.
Because people, first, because we are Africans, people will tell you umerogwa, you need prayers. And then everybody, Posa, I have drunk things. Nowadays, I'm in the space where I say, leta nitapelekea daktari, akikubali nitakunywa. And then I just pour it in the dustbin because I'm like, what is it you think at this point, 6 years and counting, sijakunywa, like ni nini yo? And it just makes me sicker. Those things don't work. They don't. Kwanza, there's that one that's very notorious on Facebook. That stuff is not sorting endo. Let's stop the lies. It's not helping.
Iwafikie. Okay, so then I know we don't have a psychologist or a psychiatrist, but what can we do to support people like Becky, and especially husbands who want sex on demand? It's not Sabbath, I can say such things. Yeah. What are Wanjiro, I think you have a psych education kidogo. Rusha, just bring it over here. What are you doing to support people like Becky?
Well, I really think, as I said again, that it is a multidisciplinary approach for endo. You must, as the doctor, I sympathize sometimes, because I do know someone will it's a very hard thing to live with, because this is your life. There is no cure, there's relief, but for very short periods of time. So I really recommend that my patients see. For me, I have a psychologist who I send my patients to, both because of the fertility aspect, but she also deals with patients who just have this chronic pain, because I do feel it's what Becky was saying. There is a lot of depression with it. And and that is normal. If I had pain every single day of my life, am I not going to ask myself why me and all these other questions, So I really feel that it's important for them to work with a psychologist in the journey of their endo. And we do, for me, I refer patients to a psychologist.
Fair enough. Okay, let's tackle the myths and myths that surround endo with the herbal one to make uko kando. Are there any other myths that we need to tackle? And hopefully we will end on a happy note, because I'm just sad.
So maybe Dr. Shwani, I attended a meeting by AGL, and it was brought by different advocates, and I think this is for the patients who will be here. Do you mind if I just share this? And
Sure.
Just the question you're asking all of us, and I found this coming from someone, an endometriosis advocate who has suffered endometriosis and had worked with really great endometriosis specialist, might have a place follower. So let me see if I can you can see my slide?
Make sure you share the sound.
Okay. Can you hear the sound?
No, did you share, when you were sharing, there's a kidude over down there, when you're on the share screen, there's share sound.
So share screen.
Yeah, then down there, there's share sound. Have you seen it?
Multiple, okay, no, advanced, okay. No, I can't. So when I hit share, right?
When you hit share, there's share, there's down there, there's share sound and optimize for video clip. Share, click blue tick the share sound, then share.
Oh, okay, sure. I got it. Okay. So
Kenyans, you can eat because it's late.
Kenyans and Tanzanians can eat.
Wonderful connections beginning to form. But what would you like to see with surgeons and patients partnering together?
Well, I think some early examples of things that are working well is Cleveland Clinic and Kara Robinson King. When they get complex cases, their team meets and meets with the patient, discusses the approaches, and they actually go through the imaging and the plans for the surgery that day. I think I would like to see more teamwork instead of a single surgeon taking a patient to surgery and then suddenly discovering that you know, the ureters are involved and it may be more than they can do, or that there's more invasive bowel work needed. So often the patient gets referred to an independent bowel surgeon and the patient doesn't know what to expect. Ostomies come up. Many of the experts are now saying ostomies don't happen very often, don't need to happen very often. So I think what I would like to see is that patient and caregiver conferences where everybody is having input into what's the best option for this patient.
Yeah, and the reason why I thought that this was important is endometriosis is, you know, is quite challenging, and the only way is just, you know, what you have planned, whereby we as caregivers and the recipients of this care, we can come together and have a forum like this, have a discussion, and see. We also need to learn the experience from our patients and then give our point of experience. That's the only way we will possibly going to give hope to patients who are suffering from endometriosis, because where we sit, we as clinicians, is a very difficult condition, but you also need to understand where patients are coming from, and hopefully this team work together can give us some future hope for the management of endometriosis.
And for people who want to dive deep into the whole endo without reading a textbook, the Endometriosis Summit, which is part of what you've watched, I watched all their videos, all of them. They are fantastic, and it helps the patient. It's multidisciplinary. They're over. Becky, do you remember how many videos there are? There are over 30 videos. Just what, instead of listening to Maina in the morning or Mbusi them, you can listen to one video on as you in the Nairobi traffic, and you will be very well educated. Okay, the myth. Then let's tackle the myth that Saya, I think he stepped out, had brought on what is it called? Menstrual cups and endometriosis. I don't know. I can't see the link, but so it's a myth somewhere there out there. I've never heard of it, but this is my brother. I can throw him under the bus. Has anyone heard of what's with the connection between an endometriosis, the menstrual cup and endometriosis? I've never heard.
I've not had, but I'm wondering whether it's, you know, there is a theory. Again, we said this is a theory of, I mean, endo is a theory of diseases. That you retrograde menstruation, where some people have the menses going backwards into the tubes, and that's how you get endo. And I have seen that. I've gone in for a laparoscopy, and the patient is just shortly after her menses, and you actually see blood in the cavity. So I'm wondering whether, and this is theory, whether that menstrual cup, people think that maybe now it doesn't allow blood to flow out, and therefore the pressure goes back. Maybe that's the theory, but the menstrual cup, I think, can hold 20 mL of blood, and a normal menstrual cycle has 80 mL of blood. So, and patients change them regularly. So I really doubt that it will, you know, go back. And even the cavity of the uterus is about 30 mL when you've never given birth. So I don't think there is any association. This is science. This is a science and physics talking. So, but maybe that's what people think.
And the same thing would be applying to tampons. Then if it's the backflow, no, it's a theory we are saying, as in the myth. Okay, I don't think we have many myths to tackle, but what's a message we are I just want us to address school nurses, parents who think teenagers are pretending when they have crazy menses like the ones Becky had when she was in high school. First of all, I am very against boarding school, so we can jump that hurdle. But what do we need to address? Do we need to do these talks in high school so that the matrons and the school nurses can get it? This is a very Kenyan setup.
So I think the first thing, if you're going to tackle when it comes to school nurses, I don't even think the talks at this point is going to help anything. because school nurses are angry people who just think we are sitting there pretending, doing our worst. If you ask me, the best way, if I go to my parent and I say, I'm having abnormal period and all that, can our parents listen to us? Because teachers and nurses are not going to listen to us. That's the truth. Can we stop sending our children to boarding school? You find out your child is having some sort of problem, please pay attention. For me, Posa, and you know this, my problem is that nobody is listening. This is the problem. Nobody is listening. It is your friends saying you're pretending. It is your employer saying you're looking for excuses to skip work. It is, you know, your family saying it can't be true. You cannot be sick all the time. It is the doctor saying you're just doing this to get painkillers. The pain is imagined. It's in your head. It's not there because if I do this, you're supposed to feel this way. You did that, but I'm still feeling this way. I'm not feeling the way you want me to feel. And this is my body. Can we start by what Dr. Njagi said? Can we listen? Can we listen? And then definitely school nurses and teachers are not going to listen.
Okay. Because it's 2.5 hours in, we cannot go on too long. Let's tufunge kituo. So last words, and if they can end in hope, I'm gonna be so happy. Let's start with you, Becky, and we'll share. Becky, of course, is looking for funds because, as you can see, we haven't solved it. I'm really pushing for her to go see Dr. Njagi. But
Yes.
I'm gonna share her flyer. Mkiguzwa mumuone. Becky anza kuongea maneno yako ya you're not dying, but funga kituo.
Thank you, Dr. Njagi, for coming on here. I actually feel like I've learned a lot because it's that thing you're saying. When they did the hysterectomy, it was that I'm supposed to feel better. And so it is that when you go back to say there's no relief, then the doctor is like, what do you mean? We took out the uterus. And then now I just had a laparoscopy and I'm still not feeling better. Actually, I was just on call with my doctor and he's like, you're supposed to be feeling better. But I am glad because for a very long time, I've been feeling like I'm crazy. Like perhaps I'm imagining the pain. I'm just glad to know that I'm not imagining the pain and that there's doctors. There's you, there's Dr. Ndegwa, there's Vicky. I'm glad that there are people who are sitting and saying something can be done. You're not alone. I don't Google anymore. I stopped. It's more scary than listening to the doctor. But thank you so much for, you know, all of you on this panel, just sitting here and saying we are listening. And I think this is the first step. Then there is hope because if people are listening, there's hope.
Namtange. Okay, Vicky, you're up. And what's the Swahili word for because we used to say daktari wa mazoezi when we were sending someone to physiotherapy. So for pelvic floor, what do they call you? Daktari wa mazoezi I'm just wondering.
That's a nice one. I'll research on the Swahili name. Dr. Njagi, what can you say about that? Utanipa jina gani?
Tafutia moja. Actually, Becky is the one who is in Tanzania. She should be the one who is, you know.
I don't even know what endometriosis is called in Swahili. What is it called in Swahili?
It doesn't have a name in Swahili. There are so many things, and once you work on this side, there's a difference. You know, like the way you go to the doctor, and the patient just says, "I have hypertension." They state it in English. It's so easy, but in Kenya, niko na shinikizo la damu, pressure yangu imepanda. The difference is very. I feel like sometimes there's a thing that's missing there's an injustice we do to Kenyan non-English speaking patients, we who trained in English. I don't know, Kizungu imeisha and my English show meter person is not here, but there's a disconnect. There's a lot to do. Leo nimechoka kichwa, but tutakuwa tu sawa. Vicky, go ahead.
Thank you, Dr. Soni, for this opportunity. I think all of us have learned a lot. And my take message is that let's take the rope and pull out each other by listening to embracing multidisciplinary approach.
Hallelujah.
Thank you.
Wanjiro, because we'll leave Njagi as because he's the end of guy as last. Wanjiro, go ahead.
So I just want to thank you guys. Thank you, Posa. I think the forums are very, very informative. Even for me, we keep learning. But I just want to encourage anyone who is dealing with endo to just be encouraged. I know Posa is that, it's downhill. It's not downhill. I mean, there is some light. And we sympathize with you as doctors. And I think we are much better placed and we're doing much more for our endo patients. So yeah, let's work together, as Vicky said.
Jagi, you're up.
Well, yeah, thank you. I think I want to thank you, Dr. Ashwani, I know you've been very flexible for this to happen. I think in a day, I don't know how much of endometriosis I get to do. I had a meeting early today for endometriosis. I was video shooting for my social media. So I think most part of the day has just been endometriosis. But I am really glad that there's a lot that is going on and there's lots of conversation that are going on around endometriosis, more so in this part of the world. And just speaking to the many Beckys who are out there is just, hope that there's a lot that is being done and there are people who are committing themselves and fully emerging all the effort they have towards endometriosis. You ask us why we are so engraved in endometriosis. I honestly don't have any idea. We have to appreciate one thing, that endometriosis is endometriosis, and we have to respect endometriosis. What we are working on, and this is what the science world is trying to find solution, is if we don't do much to endometriosis, can we shorten the period when we get to catch endometriosis? Because if we catch endometriosis early, that the prognosis and the outcomes are less detrimental as compared to when we catch endometriosis when it has involved the bowel and so on, because now the treatment options are less, the surgical procedures are aggressive. And there's a lot of work that is being done. There's a lot of biomarkers. People are studying biomarkers to find, is there something that we can pick up early enough to suggest that there's endometriosis? But what I really feel we really need to do, and this is a thing that we ended up talking about, is awareness. We need to talk about it. We need to talk about it. It doesn't matter. I find myself talking to my 10-year-old daughter. If you ask her what is endometriosis, she knows what endometriosis. She might be younger. The mother says, "Why are you telling her about endometriosis?" Because she knows her father is very passionate about endometriosis, and she might go to a high school whereby she might be able to save one or two of her friends who could be suffering from endometriosis. What time do we start talking to about endometriosis? Please just talk to these young girls in high school, because this is the earliest place that we can catch them, when they are still in school. And this is something that we are committing ourselves to do, that we hope that per year we'll be talking to more than 10,000 of young women who are in high school. The reason is because, yes, the nurses might not give ear to us, their parents might not listen to us, but these young girls, they have access to phones today. So they have access to the internet. And even if their parents don't listen to them, even if their mothers don't listen to them, the moment they finish high school, they have access, they can see it. There's a doctor who came to our school and talked about something called endometriosis. And the moment they Google endometriosis, that might be the gateway to them looking for solution. So we have to find any possible option that we have. And the best people to talk about endometriosis is going to be you, Becky. If I talk about endometriosis, I honestly have conflict of interest because you come to me as a doctor, I'm going to charge you. So there's conflict of interest. So patients, and what we've said, we need to collaborate together and we need to create awareness. It might be difficult for us to win endometriosis again because it's endometriosis, but we can offer patients and we can offer people who are undergoing endometriosis some level of hope and improve their quality of life, prevent their fertility issue getting worse. So this is my hope, and this is what I see happening in the coming years. And how is it going to happen? Is having conversation like we are having today. I think we've had 30 people who have joined in this this conversation, but this 10 could mean 1,000 who are going to benefit from that. So it has this exponential additive effect. If we commit, talk about it, I am looking at a future whereby our granddaughters will not have to suffer endometriosis for this extended period of time. And if we can commit ourselves to this, I think it's possible, it's doable. So mine is to really appreciate this opportunity being here and talking about endometriosis, something that I am extremely passionate about.
Thank you very much. And please share your clinic numbers so that I think I have everyone. Footsteps to Fertility, Lymph and Pelvic Care. Becky, wewe ni mtu wangu hauna clinic. Okay. Thank you very much. The person who usually closes us out is gone. I appreciate the expertise. I learned so much from you guys, and thank you. We'll change our people one person at a time. Thank you for what you're doing. Because I'm a Christian, may God bless you all. And if I look for you next year, just say yes. I still don't have the funds to fund you guys. I wish I could, but we resume our meetings in February because we appreciate Kenyans have to have fun in December, and in January they have to be broke. We just totally understand. We get it. There's nothing we can do. We have peculiar habits, but we'll see you in February. If you can, please share this video. At least it will change someone's mind. Even for the endo warriors like Becky and Faith, sijasema jina ya pili, Faith are here and they're learning. As in they've learned something about their disease that they didn't know. I have learned so much. I have so much empathy for you. So share, subscribe to our channels, and tukutane makutano mwezi wa Februari. Asanteni.
Thank
All
you.
right. Thank
Okay.
you so
Thank you,
much.
And
Professor.
bye-bye.
Bye-bye.
Thank you.